Hello, everybody. Over the next few minutes, we will discuss how to balance the risks and the benefits of the MRI pathway. Here are my recent disclosures. You should all be aware that the major benefits of the MRI pathway arise from its negative predictive value. That's to say, reduced diagnoses of indolent cancers and reduced numbers of biopsies that are performed. There are also benefits arising from the positive predictive value, which are more accurate determinations of grade and volume, and a slight increase in the detection of clinically significant disease, particularly for men who have had a prior negative biopsy. The benefits of MRI come from the true results, true positives and true negatives. So true negatives means you reduce the number of biopsies that are being done and you reduce over-diagnoses. The benefits from a true positive is the timely detection of clinically significant cancers with appropriate timely therapies. The harms come from the false results. False negatives are missed cancers. In other words, delayed treatments. False positives mean that patients undergo unnecessary biopsies and all the side effects of that. And two, you overdiagnose patients with insignificant cancers, and that leads to overtreatments, including long-term active surveillance costs and procedures. So we're always trying to balance harms and benefits, but we also need to account for the variability in these parameters. So if you look at the negative predictive value, you'll notice that the negative predictive value is high. In this particular analysis, you can see it's 88%, but you'll notice that the variability is quite low. In other words, the false negative harms are consistently low. On the other hand, if you look at the positive predictive value and that variability, you can see it varies a lot from 25% to 75% in these 25 mostly US centers, which means that the false positive harms are inconsistently high. So remember that harms are not equivalently rated because of this. The false positive harms are greater than the false negative harms. But remember that the tolerance of men to false positive results has to be weighed because it can be different. So if you have a man who is biopsy averse, a low risk man with a slightly elevated PSA, then remember he's more concerned about overdiagnosis and biopsies, and he's less tolerant to false positive results because he doesn't want biopsies, he doesn't want overtreatments. On the other hand, at the other extreme, you have patients who are cancer averse. So biopsy averse on one side, cancer averse on the other side. Cancer averse patients are patients who have a family history. Patients who had persistent suspicion after a prior negative biopsy. Men who have had a negative MRI before, but PSA keeps going up. What do you do about these men? These people are more tolerant to false positive results because the idea here is to increase cure rates for men with important cancers. So we're always trying to balance benefits and harms, and we know that the biggest harm comes from false positive. So how do we reduce false positives? Well, there's a number of strategies that we can use. And we're going to focus on the false positive side. We're going to assume that we have an MRI that is indicated. We've done the correct protocol that's optimized for the prevalence. We have good MRI quality. We have good radiological expertise and biopsy expertise, and we're all working within MDTs. So if you got everything right, how can you deal with false positives? Well, one of the things you need to do is to improve the MRI reading even further. And we'll talk about that. We can look at ADC values and we can talk about artificial intelligence. So do false positives look different to true positives? And the answer is yes. So false positives have, generally speaking, lower PSA densities, one or two small inconspicuous lesions. They're not very restricted diffusion. The ADCs can in fact be quite high, and they're often of diffuse fuzzy type of picture, whereas clinically significant cancers tend to be conspicuous. A lesion, you have an index lesion, you have a lower ADC, it's more focal, it's more restricted. So they do look different in the literature. So here's a typical man with a PI-RADS 3 case. You can see this dirty looking peripheral zone. Is there a clinically significant cancer here or not? It's just a common problem that we have. But if you look at the use of an AI to reduce false positives, you can see that this lesion here was eliminated by the AI. So we can use an AI to also reduce false positives. So at this stage here, this man who has no family history, no urinary tract infection, LUTs, but you can see here that he has a slightly elevated PSA. So he is at the start, he is biopsy averse, but he has a dirty looking prostate gland which looks a bit suspicious on the left hand side. But because his PSA density was low, he decided not to have a biopsy but to have a follow-up PSA. He had a follow-up PSA and you can see that the PSA has gone up. So now he's becoming cancer averse. So he was biopsy averse before, now he's cancer averse. Look what's happened to his PSA density. It's increased from 0.11 to 0.16. If you apply the AI on this occasion with the false positive reduction engine on, you can see both sides are now suspicious. So you can see how you can use the AI, one, to reduce the number of false positives, but the AI is also showing you now in doing follow-up that actually there are lesions in both sides of the prostate gland, so this man needs a biopsy. The AI can also be very helpful for improving the variability between radiologists, which is what we said was a problem with the false positives, because it was the positive predictive value was very inconsistent. And if you look at the performance of an AI to improve concordance between radiologists, you can see it statistically improves the concordance between radiologists. There's other things you can do. First of all, you can adjust the threshold at which you perform a biopsy. What do I mean by this? Generally speaking, in secondary care, we say PI-RADS 3, 4, and 5 are positive MRIs, and that's when we do a biopsy. And you can see all of these false positives on this side. What stops us adjusting the threshold to 4 and 5 only? If you look at that, that looks better because the number of false positives is less. The number of true negatives increases. Of course, the problem is false negatives also increase. So PI-RADS 3 to 5 is actually better for secondary care because of the raised PSA and the higher clinical suspicion. It results in a higher sensitivity for clinically significant disease, but of course you get a lower specificity, but you'll get more false positives. So we have to accept more unproductive biopsies, more diagnosis of clinically insignificant cancers, but you can balance this, as I will show you shortly, by using PSA density, particularly for PI-RADS 3 cases. Now, what about PI-RADS 4 and 5? Well, if you use PI-RADS 4 and 5, this is suitable for men who have a lower prevalence of disease because there's less likelihood of having clinically significant cancers when you have a negative scan. So you get less false positives, which is what we want, but you will get more false negatives, which we can somehow temper using PSA densities. And PSA adjustments are not needed for the positive cases, but are more needed for the negative cases. So let's talk about the PSA density and how we could use that to further refine risk stratification. So this is data that some of you may have seen before. You can see that we've got PI-RADS levels at the bottom here, PI-RADS 1 and 2, PI-RADS 3, PI-RADS 4 and 5, stratified by the PSA density. And these are clinically significant cancers here in red. You can see that if you have a negative MRI, if your PSA density is more than 0.2, there's more than a 10% chance of clinically significant disease, and you should biopsy that negative case of MRI. If you look at PI-RADS 3, you can see that the PSA density in fact drops to 0.1. So although here it's 0.2, here it's 0.1. So you have to adjust the PSA density depending on the MRI. So these men here have more than a 10% chance of having clinically significant cancers, so they need a biopsy. And of course, everybody with a PI-RADS 4 or 5 deserves a biopsy. Now, what I'm going to do is change these proportions to the numbers themselves. So these are the numbers. So you see this U shape, and you should get a U shape in your practice. If you're not getting this U shape, then there's a problem with your practice, and we can talk about that at some other stage. So if you biopsied only PI-RADS 3, 4, and 5, what will be the consequence? If you look on the right-hand side, you can see that 38% of men avoid a biopsy, but you miss 6% of cancers. Remember, we said we miss less than 10% of cancers after a negative MRI, and that's exactly what that's what you can see over here. Look at the number of false positives, 45%. Previously, we said false positives are anywhere between 30 and 50%. So this is exactly what we would expect. Now, what about if you biopsied PI-RADS 4 and 5 alone? Well, you'll see that the number of biopsies avoided increases from 38 to 49%. But of course, you're going to miss more clinically significant cancers. You can see from 6% to 11%. So it almost doubles. That's the problem. But you'll see the number of unproductive biopsies, false positives, of course, will go down from 45 to 30%. Now, we could be a lot more sophisticated, couldn't we? We could biopsy just men with a negative MRI with a higher PSA density, intermediate scans with a PSA density of greater than 0.1, as we've discussed, and everybody with a PI-RADS 4 or 5. What will be the consequence of that? Well, if we compare it to the current standard where we're biopsying everybody from 3 to 5, you'll see that the number of biopsies avoided is exactly the same. It's 38%, so that's not different. The number of missed cancers is exactly the same, 5, 6% on both occasions. But look at the number of false positives. The number of false positives or harms goes down. You see, from 45 to 38%. And you can see how this is a better method for selecting men who should get a biopsy. Now, we need to optimize the biopsy method for these higher risk men after an MRI. So remember that traditionally we used to do systematic biopsies. The MRI triage pathway says that if you have a positive MRI, just do targeted biopsies. But the EAU recommends doing a targeted biopsy plus a systematic biopsy. Whereas the gold standard or the reference standard is everybody gets a biopsy, gets a systematic biopsy, and those men with a positive MRI also get a targeted biopsy, so lots of biopsies. So these pathways have different names. the triage pathway, only a targeted biopsy. The MRI focus pathway, which is the one that the EAU recommends, is targeted plus systematic pathway. Now, if we compare these pathways, so the triage pathway, targeted biopsies alone, the focus pathway, which is targeted plus systematic, which is what the EAU recommends, or this more sophisticated method that I just showed you, and I'll just expand it out. This more sophisticated method is called the risk-based pathway. So in other words, if you have a negative MRI and a higher PSA density, you get a biopsy. If you are a PI-RADS 3 and you have a high PSA density, then you get a targeted and a systematic biopsy. And then if you're PI-RADS 4 and 5, you get a systematic and targeted biopsy as per the EAU recommendations. What would be the consequence of this more sophisticated way of doing it? Well, if you compare these outputs, what you'll notice is that if you use the EAU recommendations, you detect 98% of the cancers that are there. Okay. But if you use this more sophisticated method here, you'll see you still detect 98% of the cancers that are there. So they're equivalent in terms of the detection of clinically significant cancers, which is what I showed you previously. But if you look at the number of insignificant cancers, you'll see that you reduce the number of insignificant cancers, which is what you want to do. So this more sophisticated method of biopsies is actually the way that we are now headed in terms of how to decide who gets what sort of biopsy. So is MRI inadvertently leading to over-diagnosis and over-treatments? We know that there is a quest for doing targeted plus systematic biopsies, because that's what the EAU recommends. There's a quest for doing these hyper-precise targeted biopsies, and this is leading in some cases to risk inflation, particularly for men who are on active surveillance. Let me show you an example. So this man is on active surveillance for prostate cancer. You can see that over 5 years, his PSA has gone up from 4 to 7.3, and we see the emergence of a tiny little lesion, and he gets a hyper-precise in-bore biopsy. When we biopsy this, what you notice, he's got Gleason 4+5. So we're saying this is now clinically significant. But is this over-diagnosis? We're just picking up a small cancer in what is likely to be a larger field change. So this hyper-precise biopsy may be what's called the Will Rogers effect or a stage migration effect. So what's happening is, this is what we see. Remember, this is what we see on the MRI, the most visible part of the MRI, because it's the brightest bit on an ADC map, for example. On a high B value image, and the lowest on an ADC map. We also know that we underestimate the volume of the disease consistently on an MRI. So there's a lot of the disease that we don't see, but we do see these spots here. And when we do these targeted biopsies, there is an inflation of risk that's occurring, the Will Rogers effect. As a result of this, some people are saying that actually we need to adjust what is clinically significant cancer for these targeted biopsies. And we should, instead of going for 3+4 to be clinically significant, we should go for 4+3, and the reference is there on the left-hand side. Now, how do we overcome this issue? Well, one viable method of overcoming this issue is to perform what's called a regional targeted biopsy. In other words, not only biopsy the lesion, but a penumbra around the lesion, putting an increased number of cores, but not as many as you would need for a systematic biopsy. And we now know from systematic analysis that this regional targeted biopsy approach is in fact as effective as doing targeted plus systematic cores. Okay, so we use fewer cores overall. We don't do cores on the contralateral side at all, and we can reduce the diagnosis of indolent cancers. So this looks like the way to go. We will also need to adjust histological thresholds, and in fact the ISUP is now recommending an adjustment of how these targeted biopsies are performed, and you can see the reference on the left-hand side. So regarding the number of cores around the MRI targeted biopsies, remember we don't see the entire cancer. Well, it turns out that the closer you get to a lesion, the more likely it is that you will have clinically significant cancers, in other words, grade group 2 and above. The further you go away from the edge of a lesion, the more likely it is that you're going to get insignificant cancer. So these insignificant cancers will be 6 times more likely than a clinically significant cancer. So what is this sweet spot? Well, the sweet spot depends on the size of the lesion. So if you have a category 5 lesion, the penumbra is less than 5 millimeters. If you have a lesion that's PI-RADS 4 category, then it's about 10 to 12. And if you have a PI-RADS 3, then of course you need to go out more because these lesions tend to be more diffuse. So we need to be more sophisticated about overcoming over-diagnoses and over-treatments. Since the risk of death from a negative systematic biopsy is very low over 15 to 20 years, so it will be for after a negative MRI, because remember we said there is a low and consistent low false negative rate. So systematic biopsies in these patients is unjustified unless it's a red flag. This red flag is of course the PSA density. Number 2, we need to be more refined about patient selection when we decide on the PSA, decide who needs a biopsy. And again, this speaks to the use of PSA density or other risk factors. Number 3, we need to be careful about doing targeted plus systematic cores, because for every man with clinically significant cancer that we detect, we are detecting one clinically insignificant cancer. And mitigation for this is additionally required, and that is by performing regional targeted biopsies or focal saturation biopsies. And finally, we need to adjust the histological definitions of what is clinically significant cancers. So here are my 5 golden rules for balancing risks and the benefits of prostate MRI pathways. 1. Before you perform a biopsy, weigh carefully the benefits and the likely harms resulting from the MRI results. This is important. Remember, you need to consider the patient's priority and tolerance to false positive results. You need to adjust who gets a biopsy depending on the PSA density. Remember, red flags are important. In other words, clinical factors such as PSA density, family history, DRE findings, risk calculators, whether patients are on active surveillance or not, prior histology are all important things that we also need to consider. Of course, this is on top of excellent MRI. Excellent MRI means end-to-end quality of the diagnostic chain with robust, audited, and multidisciplinary working. If we can get all of these things right, we can change the balance of risk and benefit of the MRI prostate diagnosis pathway. Thank you very much for listening. I hope you found these comments useful.